I've got an excellent faculty, and we are going to talk to on the various ways about IOL fixation, whether it's a glued IOL or a sutured scleral fixation or an iris claw lens and dropped IOLs also. We have an excellent faculty. I am Dr. Mohan Rajan, and along with me is Dr. Amar Agarwal. He doesn't require any introduction. He is the supreme, I would say, as far as ophthalmology in this part of the world is concerned. And then we have Dr. Sujata, who's going to talk to us on sutured scleral fixation lenses. And then we have Manoj Khatri on dropped IOLs and Nivian on the lens as well. So let's go through this. First, the PCR 10 commandments. As you all know, early recognition combined with advanced instrumentation enabled effective management of posterior capsule rupture during phacoemulsification. Any stage, the PC rupture can occur during hydrodissection, nucleus removal, cortex removal, posterior capsule vacuuming during IOL implantation. So, if you don't manage the PCR properly, then you can end up in problems like retinal detachment, cystoid macular edema, and very, very rarely, not very rare, very commonly, is because the incidence of endophthalmitis can go up in PCR patients with vitreous loss as well, as high as 4 to 5 times. What are the early signs of PCR? Sudden deepening of the anterior chamber, loss of lens followability, lens tilt or deepening of the posterior chamber as well. Let's go through the 10 commandments very quickly. Number 1, okay, anticipate PCR in traumatic cataract, cataract post-vitrectomy. Nowadays, a lot of injections also, anti-VEGF, posterior polar cataract, dense brown cataract, pseudo-exfoliation, small pupils, and all these are what you call red flag signs as far as PCR is, and have a plan A, plan B, and plan C for these patients. Look at this particular video. You can see here there is a sudden deepening of not only the anterior chamber, but also the posterior chamber. If sudden deepening occurs, then there is an underlying disaster in the form of a PCR. So this should give us an early indication. So you should be able to recognize this PCR much early. Number 3 is loss of lens followability. Why the lens followability is, in fact, despite the fact that you keep increasing your aspiration flow rate in a peristaltic machine or a vacuum in a venturi system, the lens does not come into the phaco-port, that is, the nucleus does not come to the port as much as you anticipate, or as much as you expect. The sudden loss of lens followability should give you an indication there's an underlying disaster like a PC rupture. PC rupture during hydrodissection and sudden contraction of pupil, that is called the pupil snatch sign, which has been described by Ron Yu. You can see here, as I'm doing the hydrodissection, the nucleus. You can see that particular thing, and wherein the hydrodissection, if you don't decompress the nucleus after every wave of hydrodissection, this is what will happen. You can see that. Look at this anterior capsule very carefully. When I do the hydrodissection, you can see how it's opening up, because there is an increased pressure between the nucleus and the posterior capsule, and the anterior capsule opens up, and sometimes the pressure can go and produce what is called an acute capsular blowout syndrome. Avoid hydrodissection, posterior polar cataract, traumatic cataract, previous vitreoretinal surgery. Be careful about that. Avoid removal of instruments is very, very important. If it's a small PC tear, you can convert that into a posterior capsular excess, because the posterior capsular excess definitely has got a better stability and strength, and you can go ahead and put the lens in the bag without any problem. Large PC tear, as you know, the bimanual vitrectomy is because vitreous acts like a slinky. You need to have a separate infusion and aspiration and cutting or AC maintainer. So separate the infusion or the irrigation from the aspiration, or the irrigation, the cutter as well. So this is a coaxial thing, the animation which has been described by Bobby Osha. When you have a coaxial, when you have PC tear and you have coaxial irrigation aspiration, the PC tear starts enlarging and more vitreous starts coming into the anterior chamber. And what is the initial PC tear of about 2 millimeter can enlarge to about 6 millimeter, and you lose. Not only that, there can be traction on the macula, traction on the vitreous base, and all these problems can occur. Whereas if you have a bimanual one, which is one of the most important thing, is if you have a bimanual wherein you have a separate anterior chamber maintainer and a separate irrigation or a separate cutter, then it prevents the hydration of the vitreous and also prevents the enlargement of the break as well. High cutting rate, 3,000 to 4,000. Nowadays, it's available in all the machines. And number 4 is do not pull out. When you have a PC tear, most important thing is do not pull out of the eye. If you pull out of the eye, what will happen is the PC tear will start enlarging. You can see here in this particular case, the PC, you get a PC tear, you become jittery and come out of the eye. If you pull out of the eye, you can see that the PC tear starts enlarging and more vitreous will start coming into the anterior chamber, and even the nucleus started descending into the vitreous cavity as well. Number 5 and 6, when you have a PC tear, always make sure that you introduce preferably something like a viscoat. Because the viscoat will go and plug the PC tear. That's very, very important. The viscoat will go and plug the PC tear. You can see here I'm trying to remove the last nucleus piece because of the post-occlusion surge. This happened long time back. I'm having a PC tear there, and I'm injecting viscoat. I'm not losing my calm here. I'm injecting viscoat. What will happen is the viscoat will go and plug the posterior and slowly withdraw the phaco handpiece from the eye. So this is a stabilization of the anterior chamber is very important. They immediately create a right side port and go bimanual, which we always do when you are in coaxial. Always go bimanual. Number 7. Techniques. Use the right side port because normally you are in the coaxial irrigation. Some people do the bimanual irrigation aspiration, but bimanual technique is always important. Wherein you cut you separate the irrigation from the aspiration or the irrigation from the cutter. Keep the irrigation always there and change the cutter and the aspiration port. So the bimanual is very, very important. Number 8 is central anterior colorless substance. You know the presence or absence of vitreous unless you put preservative-free tricot, dilute it 1:3, and you can do that preservative-free tricot, and we can delineate the vitreous. Always remove the vitreous first and then remove the cortex. Don't try to remove the cortex in the presence of vitreous in the anterior chamber, because every time you remove the cortex of the epinucleus, in the presence of vitreous, you can produce traction on the vitreous base. Just to show you a posterior polar cataract, and I'm doing that, and you can see here, as I'm removing the epinucleus, there is a large PC tear, which is very, very typical of this posterior polar cataract. I inject aspiration. Once I know that the vitreous is there, you may put tricot, go ahead. Yes. And go ahead and do the anterior vitrectomy as well. You can see here again with the PPC